Good morning, everyone. Thank you for joining us for Geriatric Medicine Journal Club. We have two very interesting presentations this morning, and to start us off, we're going to hear from Amy Miles. So hopefully everybody sees Amy's slides, and can everybody mute their mics except for Amy? Thank you.
Okay. All right. Good morning, everyone. I'm Amy. I'm one of the PGY4s in geriatric medicine here. And today I'm doing the short presentation on an article entitled Scam Awareness Related to Incident Alzheimer Dementia and Mild Cognitive Impairment. The objectives for today's presentation are to review the article, critically appraise the methodology and results, and consider the implications that this study might have on clinical practice. Fraud that targets older adults is a growing concern, especially as the population ages. The Canadian Anti-Fraud Centre reported that in 2014, there were more than 13,000 reported victims of fraud, who together totaled an estimated $69 million of monetary losses. The same group of investigators that are responsible for the article under discussion today have previously investigated scam awareness in older adults. They have reported that factors such as older age and lower cognitive function are associated with greater susceptibility to scams in participants who are cognitively intact. They have also previously shown that participants with mild cognitive impairment have greater susceptibility to scams and have questioned whether scam awareness could be a predictor of the development of adverse cognitive outcomes. The paper, Scam Awareness Related to Incident Alzheimer Dementia and Mild Cognitive Impairment, was published in the Annals of Internal Medicine in May 2019. It addresses the question of whether poor scam awareness is associated with an increased risk of Alzheimer dementia and mild cognitive impairment in a cohort of healthy, community-dwelling older adults. The study draws its data from the Rush Memory and Aging Project, which is a clinical pathologic prospective cohort study that assesses risk factors for development of Alzheimer dementia. Recruitment for the overall project began in 1997 and continues ongoing. Participants undergo annual home visit-based follow-up that includes a cognitive assessment and a clinical examination. Brain autopsies are used to collect pathologic data after death. In 2010, a decision-making sub-study was added to the baseline measures in addition to demographic data and included measures of financial and health literacy, decision-making, as well as a scam awareness questionnaire. The project recruits mostly clients of continuous care retirement facilities. In the United States, these care communities usually offer 3 levels of care, including independent living, assisted living, and nursing home care, all within the same campus. Their clients tend to be Caucasian and more affluent than the population average. In order to offset bias, the project also recruits from subsidized housing and community agencies. Participants must be without dementia at baseline assessment and must consent to both annual evaluation and eventual tissue donation. Scam awareness was measured using a questionnaire composed of 5 statements that were rated by participants from strongly agree to strongly disagree on a 7-point Likert scale. The statements included, I answer the phone whenever it rings, even if I do not know who is calling. I have difficulty ending a phone call, even if the caller is a telemarketer, someone I do not know, or someone I do not wish to call me. If something sounds too good to be true, it usually is. Persons over the age of 65 are often targeted by con artists. If a telemarketer calls me, I usually listen to what they have to say. Scores from all 5 questions were averaged, and a higher score was meant to indicate lower scam awareness or higher scam susceptibility. The statements in the questionnaire were derived from results of American surveys of self-reported fraud victims, comparing their responses to non-victimized participants. The statements and the overall questionnaire have not been validated clinically, and so it is unknown whether they truly reflect increased risk of fraud victimization or lower scam awareness. Cognition was measured using 19 tests organized into the cognitive domains of episodic memory, working memory, semantic memory, perceptual orientation, and perceptual speed. Z scores for each of the 19 tests were calculated based on the performance of the analytic cohort, and a composite score that was meant to reflect global cognition was calculated from the average of each participant's individual 19 Z scores. At each annual follow-up, a diagnosis was made. Possible diagnoses were Alzheimer dementia, dementia secondary to other causes, mild cognitive impairment, or no cognitive impairment. Clinical diagnoses followed a specific diagnostic criteria. 11 cognitive tests were used and scored by a computer. Then a neuropsychologist reviewed the computer's results and rendered a classification of cognitive impairment versus not cognitively impaired. Then an experienced physician assigned a clinical diagnosis after considering the patient or the participant's history, physical examination, as well as the neuropsychologist's classification. A diagnosis of mild cognitive impairment was assigned if a participant had cognitive impairment based on the classification of the neuropsychologist, but no clinical dementia based on the examination of the physician. Of the 2,031 people who had completed the baseline assessment for the overall memory and aging project, 1,245 were eligible for the SCAN sub-study when it was added in 2010. Participants with sensory disabilities were excluded from the decision-making sub-study, and 77 of the overall cohort had withdrawn from the project. Only those without dementia were eligible for the SCAM awareness and incident dementia analysis, although they did include 189 participants with a pre-existing diagnosis of mild cognitive impairment. Participants were excluded if they were in the study for less than 1 year prior to analysis. Data were missing for 11 of the 1,077 potential eligible participants, leaving 935 who were included in the final analysis. During the mean follow-up of 5.7 years, 151 people developed incident Alzheimer dementia. Their table 1 shows that participants who developed dementia were on average older and had lower cognitive scores on their composite global cognition measure. Keeping in mind that higher SCAM awareness scores indicate lower SCAM awareness, the mean score was 3.1 for participants who developed dementia versus 2.7 for those who did not. This was a statistically significant difference in their bivariate analysis. The average scores on the SCAM awareness questionnaire were approximately normally distributed. Rates of incident Alzheimer's ranged from the lowest scores, from 11 cases per 1,000 patient years, up to 42 cases per 1,000 patient years at higher scores. Similarly, incident rates for mild cognitive impairment were higher for participants with higher scores. A Cox proportional hazards model adjusted for age, sex, and education was used to examine the association of SCAM awareness score with the risk for developing dementia. Scores on the SCAM awareness measure served as the predictor, with time in years to first incident diagnosis of Alzheimer's or MCI as the outcome. Participants who had no event or who died before an event occurred were censored at their last evaluation. In the proportional hazards model, a higher score, indicating lower awareness, was associated with an increased risk of incident Alzheimer's dementia with a hazard ratio of 1.56 for every additional 1 point scored on the scam awareness measure. The results for incident MCI were similar, with a hazard ratio of 1.47. These Kaplan-Meier curves show the probability of remaining free from dementia on the top or free from MCI on the bottom at several different percentiles of scam awareness score. For every 1 unit increase in the scam awareness score, there was a 60% increase in the risk for development of Alzheimer's dementia. A representative woman with average age and average education who scored in the 90th percentile was 2.2 times more likely to develop Alzheimer's than a person who scored in the 10th percentile. A sensitivity analysis was performed, repeating the proportional hazards model and adjusting for the effect of the baseline global cognition score on the risk of incident dementia. It showed a persistent association between scam awareness score and risk of incident dementia that was independent of the baseline cognitive scores. A mixed effects analysis showed that lower baseline cognitive scores were associated with higher scam awareness scores, and there was an independent association of higher scores with an increased rate of cognitive decline over time. For patients who died, higher scam awareness scores were associated with an increased burden of beta amyloid on autopsy specimens. And so the author's conclusions were that there was an association between low scam awareness and increased risk for incident dementia and MCI that was independent of the baseline global cognitive function. They concluded that low scam awareness was related to the pathologic hallmarks of Alzheimer's dementia. And finally, that their findings provided compelling evidence that low scam awareness was an early harbinger of adverse cognitive outcomes and accumulating Alzheimer's pathology in the brain. For our critical appraisal of the article, we'll start by examining the study population. Was a defined representative sample of patients assembled? This sample, as I mentioned earlier, overrepresented non-Hispanic white people, higher education levels, and more affluence due to their sampling method of primarily clients of the community-based retirement communities. Patients were not all assembled at similar points in the course of their disease, as there were 189 participants who had mild cognitive impairment at their baseline, who were included in the incident dementia analysis. In terms of follow-up, the mean study follow-up was 5.7 years, with a range from 2 to 9 years. And the scam awareness questionnaire has only been included in the cohort for 9 years. The study withdrawal included 77 out of 2,031 patients, or approximately 3.8%. And there was missing data for only 11 out of 1,077 eligible participants. What is not clear from the article is how many people died and at what point in time they were censored during the analysis. According to the pathologic data, there were at least 264 deaths, but overall, this number was not reported. In terms of blinding, it was clear that the neuropsychologist who assigned a classification of cognitive impairment versus not cognitively impaired was blinded to scam awareness scores, but it's unclear whether the diagnosing physician was also blinded to each participant's scam awareness score. Was there adjustment for important prognostic factors? Yes. Age, sex, and education were adjusted for in the primary analysis. Baseline cognitive scores were adjusted for in the sensitivity analysis. However, it's somewhat unclear to me how well their global cognitive score captured higher level functions, including executive function, since it appeared to focus on memory, registration, language, and visual spatial ability. Mild cognitive impairment was not adjusted for as a prognostic factor for development of dementia. Another important consideration when interpreting this study is that the scam awareness questionnaire had not been validated clinically, and so it was unknown whether higher scores truly correlated with susceptibility to scams or higher levels of fraud victimization. To summarize, the strengths of this study were the prospective cohort design, as well as the high levels of study retention and completeness of follow-up. The limitations included selection bias, the difficulty correlating scam awareness score with clinical scam susceptibility, and the fact that mild cognitive impairment patients were not adjusted for in determining the risk for Alzheimer dementia. Bottom line, poor scam awareness might be a sign of disease, possibly as a function of social cognition and financial decision-making. In fact, the same authors who published this study also published a paper in the Journal of the American Geriatric Society around the same time, May 2019, where they found that lower levels of healthcare and financial decision-making were also associated with increased risk of incident adverse cognitive outcomes. In addition, with no clinical correlation to the scam victimization, I find it difficult to interpret the risk of Alzheimer dementia in any of my patients who have individually reported that they've fallen victim to scams already. Thank you.
Thank you very much, Amy. We'll let Patrick set up his slides and we'll transition over to Patrick whenever he's ready.
Okay, thank you very much, Dr. Liu. Hopefully everyone can hear me. Okay.
We hear you and we see your slides.
Great, thanks so much. So my name is Patrick, I'm one of the PGY5s in the Geria program here, and I'm going to present on this meta-analysis. I have no conflicts of interest to disclose. So with respect to objectives, hopefully by the end of the talk, we'll have reviewed the entity of covert vascular brain injury. We'll have a better understanding of the meta-analysis selected. And then we'll have a bit of a discussion now regarding the conclusions. So
Patrick, can you get a little closer to your mic? Is that possible?
Sure, I can try to speak up. Apparently the mic is, I think, the camera itself. So I'll try to speak up.
I see.
Okay,
thank you.
So what is covert vascular brain injury? Essentially, it's thought that the numbers differ, but for every one symptomatic stroke, there are estimates that there are 10 covert brain infarcts. Covert brain infarcts are identified on imaging, but do not have any clinically recognizable symptoms. And so 2018 stroke report released by the Heart and Stroke Foundation noted there are 400,000 Canadians living with effects of stroke. So if you roughly estimate a 1 to 10 ratio, that means about 4 million Canadians have covert brain infarcts that may not have been identified. So that's over 10% of the general population. And of course, in older adults, that proportion increases. Again, varying numbers, but one study said up to 25% of patients over the age of 80 appear to have at least one or more covert brain infarcts. And just a reminder that CT sometimes does not pick up on these vascular changes. So these images are courtesy of Dr. David Stanway, one of his vascular dementia patients, research patients, who underwent both CT and MRI. As you can tell on the right side, the MRI, you can easily pick up some of the vascular changes, including the white matter hyperintensities, compared to, on the left side, the CT scan. Even though if you have a better monitor with good resolution, it's difficult to pick out the hypo densities there. Always preferable to have an MR. And so what exactly are we looking for? There are 4 features or markers that have been well defined, and we'll go through each of them, but they're white matter hyperintensities, MRI-defined covert brain infarcts, cerebral microbleeds, and perivascular spaces. So the white matter hyperintensities, I think we're most familiar with. It's increased signal intensity either on T2 or FLAIR, and it's thought to represent areas of gliosis, demyelination, axonal loss, and microinfarction. And it's a bit of a subjective call, obviously, in terms of the severity of the microangiopathic changes that you see. There are standardized scales, but my experience doesn't seem like they're used on a regular basis. And the American Neurology Association, in their their 2017 guidelines stated that was one of their goals, to try to standardize reporting of these changes. Second marker is called MRI-defined covert brain infarcts, and they're subcortical or cortical areas of atrophy, presumably caused by an infarction. On the left-hand side, you see the small, I don't know if you can pick up my arrow, but small hole, essentially. And on the right-hand side, even amongst the white matter hyperintensities, you can see the small infarct that is present. The third marker is called cerebral microbleeds. So on gradient echo, it shows up as decreased signal intensity. It's thought to be due to hemosiderin deposition from our small bleeds. So in this case, on the right side, the small black dots is the decreased signal intensity, thought to be from microbleeds. And then lastly, perivascular spaces are the least commonly defined, but they are thought to be due to vascular injury that results in dilatation of the spaces surrounding small perforating vessels. And so on T2 with flare, you'll get increased signal, looks like CSF, around the running perforating vessels. And so I'm sure you'll notice we're trying to use the term covert as opposed to silent. So as opposed to using the term silent infarcts or silent strokes. The American Neurology Association noted it's a bit of semantics, but suggests a more innocuous lesion when you use the term silent, whereas covert tends to recognize that there are subtle but important effects that these vascular changes are having. And so what are those changes? There have been multiple studies up until this point that have looked at one or more of those MRI markers to see whether they're associated with changes or increased risk in stroke, cognitive impairments or dementia, or death. And the meta-analysis that I selected to review today is apparently the first one that looks at all four of those markers and correlates it to associations with those outcomes, again, of stroke, dementia, and death. It was published in JAMA Neurology in paper October of 2018. So the author's study objective was to better understand the clinical significance of vascular brain injury. We go for a step further, ideally to optimize prevention strategies for two of the most important outcomes, stroke and dementia. With respect to their study question, so they ended up totaling 16,000 participants from 94 different trials. And the participants were either classified into the, quote, general population, which was either healthy or community dwelling adults, versus the high-risk population, which were individuals who have had a history of stroke, mild cognitive impairments, symptomatic atherosclerotic disease, depression, and a few other conditions. The authors do acknowledge that the classification and the characteristics of the population obviously are not uniform across all 94 of the trials, so there's obvious heterogeneity there. The prognostic factor they were interested in were, again, the MRI markers of the covert vascular brain injury. And the outcomes, again, three main outcomes: stroke, dementia, and death. And they further broke down stroke to ischemic versus hemorrhagic, dementia to all-cause versus Alzheimer. And they do note they did not look at specifically vascular or mixed vascular dementia because they thought the numbers would be too small. With respect to their search strategy, they only picked one electronic database as they searched Medline until December of 2017, limited to just English. And they had three different independent reviewers who would review articles for potential inclusion. And then any conflicts were resolved by discussion. And then the inclusion criteria set a priority involved only including prospective cohort studies that had 50 or more participants. And they had to have longitudinal data on the outcomes related to the MRI markers, so stroke, dementia, or death. And again, quite variable in terms of the length or duration of follow-up. And some of those details weren't actually extracted or published in the supplementary appendices either. In terms of exclusion criteria, if the study only involves CT imaging, again, because of the reduced sensitivity and specificity, it was excluded. And if it was felt that the markers on imaging, on MRI imaging, was thought to be due to a different underlying etiology, such as inflammatory disorder, a genetic disorder, either an arteriopathy or leukodystrophies, which are myelin sheath disorders, then those studies were excluded. And of course, if they were missing effect estimates or confidence intervals for their outcomes, they were also excluded from the meta-analysis. Briefly on statistical methods, so they performed meta-analyses when they had at least 3 or more studies for the same outcome. So again, for either stroke, dementia, or death. Or if they had 2 or more studies for the subtypes, so for example, ischemic or hemorrhagic, or Alzheimer's dementia. They used or calculated pooled hazard ratios using inverse variance weighted meta-analyses with random effects. Just to briefly touch on that, so I think that's a fairly common statistical calculation they use, the inverse variance, to then decide on the proportion of the weight that they give each primary study. And the random effects bit touches on the fact that I guess the 2 main methods are either to calculate with fixed effect or with random effects. If you think there's going to be more variability or heterogeneity in the effect or the outcome, then it's advised that you use the random effects mechanism, or method, I should say. And then they did do a meta-regression analysis after all of it to assess for potential confounding factors, whether it was age, other comorbidities, smoking status, education, and so on. This is the flowchart of the article. So they identified over 2,800 from their systematic search. Eventually whittled it down to 94 that met inclusion criteria. And then they broke it into the 4 different markers of covert vascular brain injury. So white matter hyperintensities had 52 studies, MR-defined brain infarcts 24, cerebral microbleeds 38, and perivascular spaces only had 5. So we'll go through the results of each of the markers. So to start off with the white matter hyperintensities, there were a total of, again, 52 studies with cumulative count of 14,000 participants. And so they found that if you had extensive white matter hyperintensity burden, and that was a dichotomous variable that was determined based on the study, then they're found to be at higher risk of incident stroke. And when they broke it down, the same held true for the subtypes of ischemic and hemorrhagic. I'm just going to spend a bit of time on this forest plot just so that we're all oriented, because it comes up a couple times. I'm just going to try to see if I can. In terms of the forest plot, so this first upper section, where there are 6 studies demonstrated by, or exemplified by the squares, and then the first diamond. So that's the general population. So individuals who are community dwelling or healthy. And so for each primary study, its estimate is identified by a square, and then the obvious straight lines are the confidence intervals. And you'll see there's fairly good overlap here. In meta-analyses, you're obviously concerned about heterogeneity within the studies, because if there's too much variability, you're obviously concerned whether you're comparing apples to apples as opposed to apples to oranges. And so in this case, visually, just by an eyeball test, you can see that a lot of the confidence intervals overlap. And then this first diamond is the pooled estimate, and you are able to go a step further and calculate a statistical heterogeneity score, and that's this I squared value that you see on the left. sorry, for this top portion, the I-square value was actually 0%. And so lower is better. So 0% actually means there's no heterogeneity. Roughly speaking, 25% means there was mild. 50% or so you could consider moderate. And 75% or high or above suggests high heterogeneity. So I didn't give the number here explicitly, but in this top section, you're just looking at the general population. The heterogeneity was excellent, was 0%. That kind of fits with this force plot that you're seeing. The second section, squares followed by the second diamond, represents the high-risk population. And as you can see there, there's much more variability. There are, in fact, some confidence intervals that don't quite seem to overlap. And so you start to become concerned about whether it's fair to pool all of these primary studies and to calculate perform meta-analyses on them. And then they took the general population and the high-risk population and calculated a total population pool estimate. And those are the numbers that I've included on the left. So for incident stroke, in all comers, they found a hazard ratio of 2.45. That was statistically significant. But not surprisingly, again, mostly because of this high-risk population, the heterogeneity was quite high, above 50%. And I'll just ask you to keep that in mind as we go through the rest of the outcomes, because the same principles will apply. So this next bit was for dementia. Again, this force plot now reflective of the outcome of dementia. Top portion again for the general population, lower portion for the high-risk population. And then altogether pooled, they found a hazard ratio of 1.84 and statistically significant. Once again, high heterogeneity, that was a statistical heterogeneity that was calculated. And just eyeballing it, you do see quite a range amongst the confidence intervals. And then for death, a little less variability based on the force plots. And eventually the final pooled hazard ratio was 2.0, again statistically significant. Heterogeneity now 41%, so a little under 50%. So we'll do that for each of the markers. So the second marker, MRI-defined covert brain infarcts, total of 24 studies, it's just over 16,000 participants. And so the brain infarcts was associated with a higher risk of, again, incident stroke. So a little cleaner, once again, in the general population, more variability in the high-risk population, and a generic score of, or I-squared score of 54%. In death, the hazard ratio was 1.64, but quite minimal variation amongst all the studies, so I-squared of 0%. And for dementia, they actually found that there was no statistically significant increase in risk of dementia. And so this very bottom diamond that you see just touches 1.0 on the hazard ratio. So felt to be not significant. Cerebral microbleeds was very similar, so statistically significant for ischemia and stroke and death, not significant for dementia. And so once again for incident stroke hazard ratio just around 2, I-squared value of 49%. Death hazard ratio of 1.53, I-squared of 0%. And then again, if you look at the final diamond there for dementia, crosses the boundary of 1, and so not statistically significant in terms of its increased risk of dementia. And then lastly, for the fourth marker for perivascular spaces, ultimately there were only 5 studies, and so it did not meet criteria to perform meta-analyses. So the authors simply stated it was insufficient data. So after all that, the authors concluded that MRI markers of vascular brain injury have major clinical significance. And they go a step further saying this should prompt detailed assessment of a person's risk for stroke and dementia and careful evaluation of the benefit to risk ratio for available prevention strategies. Later on in the paper, they also do suggest that a randomized control trial would obviously be helpful in this setting to try to determine whether pharmacotherapy such as blood pressure management or antiplatelet therapy would be beneficial in this population. Then our critical appraisal. So first, are the results of the study valid? So for meta-analyses, one of the first steps is, did they capture all the important and relevant studies, or were any missed? I guess for this study, there is a bit of a concern. They only looked at one electronic database. They limited all their studies to English. And they also did not look at any unpublished data. So concern for publication bias in that respect. To their credit, they did, of course, manually search some of the reference lists from the most relevant articles. Next criterion were the inclusion criteria that they used appropriate. And to me, they seemed so. They were defined a priori, they were clearly stated, it made clinical sense. And there were 3 different independent reviewers who would apply the inclusion-exclusion criteria and try to come to a consensus. Next were the included studies of sufficient methodologic quality. And so in the supplementary publication, they do include their quality assessment for all 94 trials. And these being cohort studies, they use the Newcastle-Ottawa scale. If you'll recall, score out of 9, the higher, the better in terms of methodologic quality. And just go through the vast majority, so over 70 of the trials would score 7 or greater on the Newcastle-Ottawa scale. There was a few that scored less. They did do secondary analyses where they excluded these 20 studies that scored 5 or 6, and ultimately their conclusions were the same. So it did not seem to impact on the final estimates that they got from their meta-analyses. And then second component of critical appraisal, so if this study is valid, what are the results? And the main question there for meta-analyses is how much variability was present. In this case, I think it's fair to say there was at least moderate variability through most of their estimates. And so both just by looking at the forest plots and the overlap or the lack of overlap of their confidence intervals, as well as the calculated statistical heterogeneity I-squared values that they give, many of which were above 50%. There's a concern that there was at least moderate or greater heterogeneity. And so ultimately, limitations to the study, like we discussed, beginning with the search, limited to a single database, only one language, did not look into unpublished literature. So concern for publication bias. I didn't include it, but they do include some funnel plots, funnel charts, I should say, funnel graphs on their supplementary publication. And there is some asymmetry in a lot of those plots, again, suggestive of possible publication bias. And then the other big concern that there are numerous sources of heterogeneity that really, obviously the meta-analysis is only as good as the primary studies that they're composed of, and there's a lot of variability in the study population, the radiographic techniques, the interpretation of the techniques in terms of who deemed whether this was extensive burden of white matter hyperintensities versus non. The outcome assessments, there was differences in terms of how they were performed to determine, for example, dementia, and the length of follow-up also quite variable and sometimes not explicitly stated. And so lots of sources of variability and heterogeneity. And so overall, my conclusion was that just given the limitations, I wonder if the clinical significance of covert vascular brain injury is not as great as the authors conclude. And just knowing that a lot of the, taking a step further, knowing that a lot of the preventative pharmacologic strategies that we utilize are not without harm, particularly in older adults. I think it just emphasizes again that you need to perform individualized risk-benefit analyses to come to the appropriate clinical decision for the patient in front of you. Of course, happy to hear what others think. And thank you to Dr. Alawai for suggesting the article.
Thank you, Patrick, and thank you to everyone for the discussion. I think it's an ongoing issue, and I'm glad that we had the opportunity to share your views today. And thank you also, Amy, for the presentation on the vulnerability to the scam as a screening. So that draws us to a close for today's Journal Club. I wish everyone a very pleasant long weekend.